Thanks very much. Thanks everyone for joining us tonight for COVID Update 12 from the Hunter New England and Central Coast Primary Health Network. Here with our colleagues from both Hunter New England Local Health District and Central Coast Local Health District. And, Jenny, can you mute everyone else?
I will.
Thank you. Great. Lost my train of thought. Sorry about that. So, yes, welcome everybody along to the 12th in this series. As always, we'll begin by tonight by acknowledging that we're meeting on Aboriginal land wherever we are across this beautiful region that we're so pleased to live in. We acknowledge the traditional custodians of this country and own elders past and present. And we take a moment to reflect on the challenges that this particular health crisis presents for our First Nations people, and they're being blessed by being well protected at this stage through a range of very, very intelligent actions, mostly being led by themselves. So thanks very much. I also want to recognise everybody who's here tonight, who's working in very strange times, and thank you for your ongoing protection of our local communities as well. Tonight we'll have three presentations. I'll give a little bit of an update of what the PHN's been up to. Tony Merritt from Hunter New England's Public Health Unit will give us an update from their perspective, and our colleague Catherine Todd can't be with us tonight from Central Coast, but Tony's going to provide an update that Catherine sent through as well. And then Dr. Katie Lai from Hunter New England Infectious Diseases is going to give us some clinical information that I'm sure we'll find really helpful. These sessions have all been great because of the questions that you've asked us. And so during the panel discussion, we'll also have our colleague Mel Pickering from Central Coast LHD online with us, and together we'll hopefully be able to answer some of the questions that we're hoping you're going to be entering busily on Slido. So hopefully you can see my next slide. Why isn't that moving? Now it is. Oh, that was all of that. So if you go to slido.com and you enter the event code PHN12, you can then ask questions that you think are of interest to you. You can ask questions that you want to know about. If there's something else there that you think is really interesting, you can like it, and that will bump it up in terms of the way that we address it at the end. And we also really hope that you'll complete the evaluation and make sure that these events continue to meet the needs that you've identified. So what's the PHN been up to? Very briefly, education series such as this one. We've been working with our LHD colleagues and responding to some mercifully small outbreaks around the region, but each time there is an outbreak, we will modify our practice and find better ways for us to respond. We've been working in an advocacy capacity with the Commonwealth about additional resources that are needed here in our region to continue to respond to COVID, and also around what we see the need to continue a number of initiatives, including the GP community respiratory clinics, MBS telehealth item numbers, and MBS item numbers for our allied health providers, particularly in telehealth. We've been working with both the LHDs on the ability to increase access to testing, to make sure that results are coming through in a timely way. And I shared my story briefly with Tony earlier that I had a test at 9 o'clock on Sunday morning myself and had the result through at midnight. So as a mystery shopper, the system seems to be working well. We've also been very much preparing for outbreaks in residential aged care. It's a massive focus for us all at the moment. And we are setting up an emergency SMS system so that we can make contact with primary care across the region as needed. So just really quickly, this information is all on our website. Access to masks and other PPE keeps us really busy. Just want to remind people there are guidelines for access. It is not a replacement for commercially available supply. We're not trying to ruin other people's businesses, but Commonwealth and acknowledges that there are challenges sometimes with access to masks. We can either respond via the forms that are there on the screen or through Capacity Tracker, and I'll talk about that a wee bit. Aged care facility, we'll have a specific session on this. There's a lot more detail going into the plans that have been being worked on either within facilities or within general practices. We've got a very much a coordinated response with our local health districts. There's been a number of tabletop exercises where we've been able to bring many of the players together and to really talk about how we would actually manage in an outbreak, and pleased to be able to support some GP attendance at some of those too, which will really help complete that picture. We are still really mindful that in an outbreak the responsibility sits with the aged care facility, and so we really are working with GPs and residential aged care and the LHDs to clarify everybody's roles with that. So we'll have an update in a couple of weeks. We've also been responding to Capacity Tracker alerts, so we've been able to touch base with quite a number of aged care facilities across the region when they're having problems accessing the mask. Hello. Everyone's on mute, please.
Where is the speaker?
Can you all hear me now? Okay, thank you. Sorry about that. Yes, so we have been able to respond to a range of alerts through.
We've lost you again, Catherine. I'm sorry.
To register in, and it coordinates a range of things, including assistance from us and PPE from the National Stockpile. How's it going? Well, we've got 70% of residential aged care facilities currently registered out of the 190 across the region, and we continue to work on that. Think that's becoming a key part of any outbreak management plan, and always happy to talk to people about that. In terms of general practices, we're up to 47% of practices now registered. Alerts that are coming through in those from the Capacity Tracker are responded to same day usually, or the next day if it's late in the day. We've been able to help people with their concerns around their ongoing preparation and safety. And we're also using that system to manage emergency contact details. So if there is an outbreak in a practice or in an aged care facility, we'll be able to work with all of the other parts of the system to make sure that we are responding appropriately. So I'll pause there, Jen, and I'll hand over to our colleague Tony Merritt from Hunting New England and ask Tony to take us through what he would like to tell us about. Thank you.
Fantastic. I think I'm unmuted now. So lovely to join you all. Let me just bring up the slides and hopefully that will work. And I can just ask for feedback from one of the organisers. Are those slides displaying now okay?
Yes, you're all good.
Fantastic. All right. And we're just doing it slightly differently than we have in the past. It's not showing for me. So, all right, bear with me. Okay, so just a brief update, and we'll move on to questions. Here's the slide. I hadn't looked at this slide for a little while. I know we've seen it a lot in the past. Extraordinary that we're up to 21 million cases, and the leaderboard there is truly horrifying. You can see why Brazil is the site of many of the vaccine trials that are being undertaken at the moment in phase 2 and 3 over 3 million cases, and getting up to 750,000 deaths. All right, there's the EpiCurve for Australia, and so clearly a really substantial second phase of the vaccine, still very much in play. Clearly Victoria contributing really substantially to this second wave, well under play. It's been a torrid time in New South Wales. I couldn't resist this slide. Credit to David Durheim for pulling together the play on words here with everything that's been happening in Sydney over the last month or so, but truly on a knife edge or at the crossroads for us in New Zealand. And we may just be coming out the other side, but my goodness, we are just hanging there. The sense from across the state, and particularly in Sydney, is that there is just so much work to do. This is a slide out of one of the Sydney papers from a little while ago, but just reminding us about how many transmission sites there have been after what was a really modest introduction from south of the border. So lots of work. That's the... Oh,
sorry, Tony.
Yeah.
Sorry, it's Catherine. I can only see the first slide. I don't know if that's the same for everyone.
Oh, well, that's really strange. Okay. Let's...
No, that's... Now we can see a slide with a graph on it.
All right, so that is a shame. We obviously got a bit of audio. Can I check? Apologies to everybody there. Let's just go across there and control panel. We needed to do more testing beforehand. All right, so I'm just going back to, apologies folks, so just go back to that presentation with a chart, and can I have advice from the organisers? They're not been advancing on my screen, but to advance that in a way that you all see advanced, what do we need to do there? I'm moving on now to a bar chart. Can I check that that's moved for other people?
Yes, it has.
All right, not quite sure what was going on. But the point I'd like to make here is that, so whilst there's lots of activity in this second phase in Australia, a great deal in Victoria, the previous chart you saw it just gave a sense of what's happening in New South Wales, and it's really different this time than last time around. Lots of local transmission, clearly lots of venues, pubs and clubs, but also schools and elsewhere, lots of eateries. And this chart is a display of the proportion across the age groups. Again, this is dramatically different than our first wave of activity, really relevant to us when we're considering who to test, and you'll see a real predominance there of young people, including that secondary school age group, really been a significant issue, some locally, but definitely in Sydney, and then young adults in the pubs and clubs. So very different profile in terms of the epi this time around. And, you know, clearly we need to remain incredibly vigilant in Hunter New England, and a lot of the risk to us is importation from south of the Hawkesbury. Okay, what has been happening locally? This is a Hunter New England perspective. We'll see from Catherine's slides a similar perspective for Central Coast in a moment. So really we did have that a long period after the peak of activity back in March and April with very few cases. This is the EpiCurve for the period since June, 17 cases, 3 clusters. I'll tell you more about those in a moment. The blue squares there are internationally imported cases, and the rest in orange represent local transmission, with just the one in grey, and where we still, despite looking incredibly hard, do not have a clear source for that importation. So as I was saying, in Hunter New England, those internationals, and then really three clusters: the family cluster in Charlestown, and that was imported from the UK. For those of you who are with us last will remember that was just a reminder that the incubation period can be right at the end of the 14 days. The gentleman who was positive there. We had the Port Stephens family cluster with no ongoing transmission in the Port Stephens area, so fantastic response both for the people who went into isolation as cases and the very many close contacts, so superb work. That was linked back to Tyrock, a couple of generations in between though. And then the more recent Newcastle family cluster, as I say, we're still unclear of the source there on genome sequencing. It's the same as the strains that are circulating in Sydney at the moment. So that's been the story in Hunter, New England in recent times. Superb response, no ongoing transmission that we've picked up, despite absolutely record levels of testing. So again, thanks very much for your part in encouraging testing and supporting people who did the right thing, going into isolation, and there were literally hundreds and hundreds and hundreds of those people. Key learnings, just accepting that the incubation period really is incredibly variable, right up to 15 days. Lots of transmission though in that first 1 to 2 days, really important to keep that in mind, and a number of really clear examples of transmission from people before they develop their symptoms. And I hope this is an important vignette to share with the people you're supporting going into that preemptive quarantine when they're identified as contacts, because transmission really can occur quite commonly before people develop symptoms, hence the importance of that. A lot of the transmission we've seen in those clusters has been in households, so just a reminder that we really need high level support for the people who are isolating in households with a case, and ensuring that the level of isolation from the case is exemplary. And where there are examples, if you develop concerns that cases and their household contacts can't isolate effectively, we really want to hear about that straight away. We've put lots of people into hotel accommodation in that case situation. And for really high risk close contacts, we will look at doing the same thing. And I guess we've covered a few times now, a positive COVID test is a really helpful thing, but we all need to be wary about negative COVID tests, both in the sense of in asymptomatic people not offering great predictions of what's going to happen in the period ahead if there's been an exposure, and in people with symptoms where you really suspect COVID, certainly the potential for those false negative tests and the need to retest based on your prior suspicion about COVID risk. Thought I'd mention the sewage story very briefly. This is absolutely intriguing. We're still on the learning curve here, but you will have seen the reports of a positive COVID in the sewage treatment plant at Burwood Beach there. Now there's a program that's right across New South Wales, and with a great many sites. There's a number in Hunter, New England, and this promises interesting utility. Now, a key issue here is that the RNA fragments from the viruses persist for a period way beyond the infectious period. So really good European evidence that median shedding time is out at 28 days, so a couple of weeks beyond when people are infectious. And in terms of explaining the Burwood result, there were known cases, in fact 6 of the cluster cases we've just talked about during the period of relevance, so plenty to explain that. But there was that intriguing result you may have seen the Perisher sewage treatment works with no known cases there. So either there was a missed case or somebody who'd been a case and was shedding but no longer infectious. So lots to learn about this, but we're really hopeful this will add an additional kind of layer of surveillance, particularly if we get to the point we're really aiming for of suppressing this virus to the point of no community transmission. It'll add another layer of assurance about what's going on in our communities. No risk for the effluent coming out of sewage treatment. The COVID virus is effectively killed. No threat to our public water supply. And my very last slide is just to touch on the aged care space. And look, this is complicated and it's a moving feast, but clearly across New South Wales where we recognise that there are increased risks in areas, then we're all extraordinarily keen to protect our aged care staff and residents. So of course there's the ongoing exemptions or restrictions that apply in any aged care or anywhere in New South Wales, excluding staff and visitors who have symptoms that could be COVID, of course, who've been close contacts of confirmed cases, and those people ought to be in isolation, of course, for 14 days. People who have been recently in Victoria or overseas, or any of the venues, and I suspect many of you visited that list. It's updated on a daily basis. So anyone who's been at a listed venue at the dates and times on that website table is certainly excluded for 14 days from the time of visit from being in an aged care facility. That applies to staff and residents. And there's the additional requirement under the public health order that people are vaccinated against influenza unless they have a validated medical exemption. So they're the same things. I think we kind of know all that. But there's this potentially confusing list of LGAs which are time limited and based on local transmission risk. And the Newcastle local government area is on that list. It's been on for nearly 2 weeks. It'll stay on now for another week. And if the news remains good in Newcastle, then it will come off. But for LGAs that appear on that list, there's some extra requirements, and we know this has caused some extra consternation, and certainly there's potential for confusion. So any aged care facilities that are in a listed local government area are closed to visitors, and staff in those facilities will wear masks while we're at work. Any staff who live in listed LGAs, regardless of where they're working, but staff who work in aged care will wear a mask at work. And the restrictions on visitors are up a level from that. So visitors who live in a listed LGA or visitors who've been in a listed LGA will be excluded from visiting while that's in place. Okay, so look, that's what I've got. I'm looking forward to questions. We'll move on. That's the end of mine. And I will hand back to and hand over to Katie Lai. Thanks for your attention and look forward to talking soon.
Katie, we can't
hear.
Still got you on mute.
Okay, great. Yeah. You hear me okay?
We can hear you now. Yes, we can.
Yeah, thank you. And you can see my slides?
Can.
Yeah, excellent. Okay, yeah, thank you. Okay, no, thank you, everyone. So thank you for inviting me to join the seminar tonight. I'm Katie Lai from Infectious Diseases from John Hunter Hospital. So the focus tonight of my talk is on infection control and prevention. So especially the fact that we know from the last few weeks from the Victorian situation, there have been many healthcare workers infected with COVID. As of the 8th of August, 1,835 workers had been infected with COVID. We know that up to 15% of these workers with active infections have been infected at work. However, the majority of them are still under investigations with no clear source as yet. Compared to a month ago, there were only 446 healthcare workers infected. So we can see the impact of the outbreak and the impact on healthcare workers. So the point is that we want to protect ourselves. We don't want to get infected. So we want you all to be protected. So the lessons learned from the Victorian situation. So there were quite a few lessons. So just a few things from the document produced from Safer Care Victoria. It mentioned that the health services or hospitals, they need to ensure that there's adequate social distancing. So especially in non-clinical areas, for example, tea rooms in the hospitals and other places. So not just clinical areas. And also because of the fact that there were lots of changes, so rapid changes in the past few weeks in Victoria, and there were rapidly changing advices in terms of infection control and personal protective equipment measures. So it was somehow difficult for the staff to keep up with. And therefore, so hopefully there should be more effective measures to keep the staff updated. And also the next one is that we don't want to underestimate the impact of fatigue on healthcare workers in terms of its impact on eroding the efforts to follow infection control and PPE guidelines. So we want to do it right. So we want to do it right every time and every day. Now, this is a new document from our Clinical Excellence Commission from New South Wales Government. So especially in the last week or so, there have been quite a few new documents produced, especially after the Victorian situation came through. So just to point to you the fact that there's a document called Respiratory Protection in Healthcare, and there's a document called Infection Prevention and Control Application of PPE during COVID. So they both came out like just a week ago. And this is a website if you want to, so this is a website if you want to look at the details of the documents. So we understand about contact precautions, droplet precautions, and airborne precautions. But what's new in the last few weeks in New South Wales is the activation of what we call Amber Alert in the hospital settings or clinical settings. Now, so what I'm showing here is the newest thing. So for routine clinical care in geographic areas with significant community transmission of COVID, the recommendation now is to use standard precautions, including eye protection, and to wear a surgical mask. So now standard precautions meaning hand hygiene with the hand sanitizer before and after you see the patient, and you put on the protective eyeglasses or goggles, and to wear the surgical mask appropriately, and to do the appropriate donning and doffing of the PPE. So the next point is that if you're looking after patients with suspected, probable, or confirmed COVID who are in quarantine or they have acute respiratory symptoms, you have to use contact plus droplet precautions, including eye protection. So the difference between these two, is that it has the additional contact precaution with the droplet precautions. So in technical terms, it means the use of long sleeve gowns and gloves, and the eye goggles and the surgical mask. So, but it does not involve the use of N95 or P2 masks. What's also new is this recommendation in which you see challenging patient behaviors in specific clinical settings. The Infection Control Excellence Experts Group recommends the use of P2 or N95 masks when you encounter clinical or look after clinical patients with suspected, probable, or confirmed COVID who have some cognitive impairment, or they're unable to cooperate, or if they have challenging behaviors, or aggressive behaviors, mental illness or issues, challenging settings. So in those cases, you have to consider the use of contact precautions, plus droplet precautions, plus airborne precautions, including the eye protection, and in that case, including the use of N95 or P2 masks instead of surgical masks. So that's again to protect ourselves. Okay, so the next point is that in these challenging cases, and also if you have many of these patients, so and/or unplanned aerosol generating procedures, including intermittent use of high flow oxygen, then you have to consider extended use of these like special respirators or N95P2 masks for up to 4 hours if tolerated, to avoid the need for frequent changes of face covering. We don't suggest anything longer than 4 hours really, because it's quite hard to tolerate, clinically speaking. So that's pretty much it of my short talk. But we welcome any questions from the audience. So I'll pass it back to you, Tony.
Okay, I think I'm off mute. Now, so Jenny, I think you're going to show Catherine's slides at this stage, is that right?
Yes, won't be one moment.
So it's a brief, as we heard at the entrance, Catherine gives her apologies tonight. She'll be along next time. Just a couple of slides that mirror the epi I shared for Hunter New England. Laura, apologies. Clearly, we were having some challenges with the slides. And just to give you a sense, there's a couple of slides here. Central Coast has been doing superbly, as those of you in that lovely part of the world will know. So no local transmission for really a very extended period of time. And just coming up now. And the next slide. Fantastic. So here's the epi curve. So this is reflects lots of hard work. Congratulations to everyone involved. So for the Central Coast, so an extended period of time with no local transmission. So those cases, that smattering of cases over the last couple of months, all relate to infection acquired outside of Australia. And the next slide, please. So in summary for Central Coast, 124 cases overall, with 1 death in that period. Apart from that person, everyone else made a full recovery. And as I said, no local acquisition on the Central Coast since early April, superb effort, and a small number of cases in return travellers. Now, Central Coast, clearly you must feel much closer to Sydney than us, and this really is a time for extraordinary levels of awareness and vigilance. So high levels of testing, critical, really low threshold to testing people with compatible symptoms, and particularly with travel to anywhere in Sydney at this time. And I think is there one more slide, or is that the end of Catherine's? That's great. All right. I think that's the end of that presentation. So, Catherine, back to you.
Hello, sorry about that. And Mel, I'm not sure if you're online, if you could pop your webcam up, and we can, hello, there you are, thanks for joining us. So we've got a few questions here, so I'm going to facilitate them as best I can for the panel. So I might start, this could possibly a question for you, Katie. That's around vaccines. So. Yeah. $1 million question, multi-billion dollar question probably. Can you give an update on the expected time frame on a vaccine? Thoughts on safety of the can you see the question? Of the novel mode of inducing immunity amongst vaccines in development.
Yeah, okay. I don't have all the answers, but I can see the question. So, and that's my question as well in my head for a long time. So, so many countries are doing lots of like vaccine development and research. So, according to WHO, there are currently about 140 vaccine researchers or developments. Some of them have moved up in terms of their stages of research. So we heard from the news, especially the leaders in research in vaccine currently are the Oxford group as well as the American group called Moderna. So, but in terms of time frame, so no one actually knows, but each group says like fairly soon. Okay, so but we expect a number of months before these can be rolled out to become publicly available, because they still have to go through stage 3, stage 4, hopefully before they're declared to be effective. So because to have an effective vaccine, so you must prove that it's effective on humans, not just animals, and also it needs to be safe, and it needs to be be able to prove that. So I try not to comment on the Russian vaccine. So the Russian vaccine that's in the news in the past week or so. So because their regulations and policies are quite different. So how they're rolling out the Russian vaccine is quite different from many other countries' policies. Yeah. Okay. Yeah.
Thanks. I was going to ask a question about the Russian vaccine, but I won't.
Yeah. Thank you. Yeah.
I don't quite understand the second part of Jamie's question, but thoughts on the safety of the novel mode of inducing immunity amongst vaccines in development?
Yeah, I think it's a question about the safety. So I don't think I have the answer for that one either. So, but I think in further research and further like statistics or data to support the safety, if a vaccine needs to come out, then it needs to have some like so good evidence to prove it and support it. So yeah, no, I'll be looking forward to seeing those as well.
Okay, thank you. I would commend people to pop some questions into here, otherwise we'll have to make up some as we go. But yeah, so if you've got any questions, please let us know. Tony, this one's possibly one from Public Health. So if a practice is required to close to deep clean areas, I'm not sure if anyone's had to do that yet, is a certificate required to verify they have cleaned and are safe to reopen? I guess a practice or any location, really.
Yeah, it's an intriguing idea, this concept of deep clean, which has snuck into press releases and the media coverage. I guess I would, I'll answer it in a number of ways. So a clear answer, no need for a certificate. I know there are companies that will do really thorough cleans and issue a certificate, but that's not required. And the kind of cleaning that hopefully all practices are now doing as a routine, obviously there's the enhanced periodic cleaning during the day and then the more thorough cleaning at the ends of the day. I mean, that's all designed to offer superb protection in terms of COVID on surfaces. And so it's that regular routine cleaning which is going to be the critical thing for us all in terms of preventing transmission, onward transmission from surfaces. Often by the time we know about a case and we're going back to places they were when they're infectious, there's a period of at least a couple of days that have passed, and that's certainly been the case for some venues in Newcastle in recent times. But reassuringly, from the venue side of things, the kind of cleaning that all of those facilities had in place was entirely adequate to control the risk of surface contamination. And the same would apply to practices. If you're doing that routine clean throughout, excuse me, your practice in a COVID safe way, likely at the start and the end of the day with frequent touch surfaces much more regularly, then that will manage this risk. Now, where we've had a venue where we know there's been someone who's infectious, look, we tend not to use the terminology of deep clean. Really what we're talking about is a prompt for another thorough cleaning, but it will usually be just exactly what people are doing on those thorough cleans periodically each day, and that's what's required. There's nothing that's particularly demanding about that. Often for people it will be that combination of a neutral detergent and something more bactericidal, and so that part of your routine cleaning. The terminology, as I say, has kind of developed a life of its own in coverage of venues in particular, but there's nothing particularly critical or magical about the terminology. As I say, it's a thorough clean. But Katie, would you like to offer any commentary on the cleaning side of things in terms of maintaining, controlling surfaces as a risk of fomite transmission?
Yeah, sure. So the frequently touched areas should be cleaned frequently. So from the CEC infection prevention website, there are quite a few documents, or there's a couple of documents to describe especially standard cleaning and deep cleaning. So especially for COVID purposes. So, and in terms of surfaces, there are quite a few chemicals which are approved by CEC, which should be used for deep cleaning purposes. I suggest a read of that.
Thanks, Tony and Katie. There's sorry, go on.
Yeah, so should I, so I'm just seeing a question about washing of gowns. Is that a good leading question to go into? Yeah.
Absolutely.
Okay.
Carry on.
There's a question from RB. Are there any protocols for the washing of reusable long sleeve gowns? So no, I don't think so. So, but from so there may be local policies if you work in a healthcare institution or facility. So you may have local policies from your managers or from your departments in regards to how to do your laundry or the washing of gowns and other materials or fabrics. So, for example, how we do it in a hospital is that, so we've got centralized laundry. So, but if you do, so just say our scrubs and uniforms. So if we to take them home and wash them ourselves, then we want to make sure that the dirty or the used fabric or clothing is put in a plastic bag. So, and when like after use. So, and then at home we suggest hot water to do the laundry. So to wash your clothes. And with detergent, of course. So, and then so we suggest washing of gowns daily at least. But if using these long sleeve gowns for the purpose of seeing patients, then we suggest the change of gowns with the use of each patient, of course. So in other words, so washing frequently and washing with hot water, and so keeping the container bag clean. So when you are taking the dirty laundry to the laundry room, that's still important. So, but unfortunately, there's no clear-cut policy or protocol that we have. Yeah, thank you.
Thank you. I'll take the next question, which is about gowns, which flows on from that. And I think this is related to the challenges of purchasing lots and lots of PPE in an environment where things are already expensive. So the PHN, so we do have access to gowns in some situations, and the explanation for that is on that website on that. So from the national stockpile, yes, we can get some in certain situations, and definitely in an outbreak time that changes quite dramatically. But we have also tried to make a bulk purchase of gowns to make sure there's some available here in the region. We don't have them yet, although we do have lots of other stuff has all arrived from all over the place. And so we can definitely help, and we can talk about how we might manage that very soon. So yeah, we definitely understand that to be a big problem for people. I might, there's a couple of questions here about from rural GPs specifically. There's one around wearing masks in areas of low community transmission or low evidence of community transmission. But there's another one which is really about how are people managing screening of visitors from Sydney and or suburbs with positive cases. So we don't have any rural GPs on our panel tonight, unfortunately, but I guess, Tony, it'd be a question for you. So we talked in your slides a lot about visitors to aged care and how people are managing people who live and have been through, I'm trying to avoid the word hotspots, but whatever we call it, listed LGAs. So do you have any advice on that one?
Well, I guess we really kind of need a perspective from the ground. I echo your efforts to not use the word hotspots. That just it's a trigger word that has an absolute life of its own, including, you know, impacting people who perhaps want to travel interstate and arrive into Darwin or Queensland. So I will just emphasise, while we do occasionally use the term hotspot where there's really very substantial transmission, it cuts through, but those listed LGAs, we're very definitely not calling them hotspots. It's a precautionary extra measure, and it doesn't trigger the kind of extra response interstate that a hotspot might. Look, the mask issue, I think, is a sensible addition to our armamentarium in a way that it clearly wasn't first time around. You know, and it is there with us all being vigilant in terms of the social distancing, the 1.5 metres, the attention to hand hygiene, making sure that we're getting tested where we've got symptoms. So well done, Catherine. And I think masks are now an optional extra in New South Wales position outside of health facilities, outside of aged care facilities. So I'm very encouraging of people wearing masks at their discretion. There is a valid question if you're in Tamworth. So if you're in I'm not sure if it related to a health facility or aged care or for people in the community. I'd encourage people in the community feeling comfortable about wearing masks. The decision about wearing masks in healthcare facilities across the state was one taken at the highest levels, but that's non-discretionary. But I support the masks in healthcare facilities, of course, and I encourage it outside. I think it's an extra step we can all take to protect the people around us. Clearly, if I'm wearing a mask in Woolworths when I do the shopping, then I'm really taking a step to protect other people around me. The key value there is preventing transmission from me to other people. So I think it sends an encouraging message. I think that there is this kind of vexed challenge for us looking at somewhere like Tamworth, given that that was the question. Clearly no local cases there for an extended period. It's really encouraging, but we are in this state of very much heightened vigilance and going the extra mile. We really want to get back to where we felt we were very close with extremely limited community transmission that would allow us to open up and do things again that, you know, we're all keen to get back to. And I guess there's a couple of things, you know, wearing masks is a compromise towards that direction. There was a great question there about how we can close the bridge across the Hawkesbury, and I know that was offered with a smile, but in fact we can make a contribution to limiting non-essential travel, and the recent changes in terms of community sport reflect that as well. I mean, we from the Chief Health Officer down, like the sentiment really is to go hard at this stage and to attempt to get back to that position with really limited and eventually no community transmission. That's where we want to be. So Catherine, I think I've rambled a bit. So masks we covered on. There was a question there as well at screening at aged care facilities, I think. And look, I'm not on the coalface there, of course, but this is just absolutely critical. And I know our residential aged care facilities are taking this very seriously, and it's just critical. Every visitor, every staff person should be screened for symptoms and temperature as they come into facilities, and that's just part and parcel of keeping those facilities safe. To you, Catherine.
Thanks. I'm just working with Jenny there to minimise her screen. Thanks for that. There's another question I'm quite interested in, and Mel, this might be just something to take back to the team on the Central Coast. They're around limited testing and the difficulties for people accessing testing on the Central Coast. I know it's not your area of expertise, but are you aware of where the facilities might be available?
We've got the COVID clinic up at Wyong Hospital, but yeah, other than that, I will have to take that back to the team, and I'm happy to provide that feedback. But yeah, we do have at Wyong Hospital a COVID clinic that's operating up there.
Yeah, and this has been raised before. It is difficult. It's not the easiest place to get to, Wyong Hospital, and particularly if you can't drive. So we will definitely continue to talk about that. So I guess one of the questions is, and this relates to, there's only 5 positive cases in New South Wales today. The risk of missed community transmission, Tony, I saw some spectacular headline in the paper the other day that said there might be 10, for every 1 case we get, there might be 10 more we're missing. Thoughts, comments?
There was a useful contribution from a Victorian epidemiologist, and look, we know where unexplained cases pop up, that it's very likely there are other unexplained, undetected cases in the community. And there's certainly been a handful of those, at least a dozen across Sydney in recent weeks, where there's still lack of clarity, unknown source of transmission. The vast bulk have been linked to those outbreaks, and the genome sequencing helps with that. And so that does point to potential for undetected cases, and that's the key driver for the criticality of widespread testing and testing at the very slightest of symptoms. I think that ratio is probably wrong in New South Wales, given the level of intense testing and the fact we tested thousands and thousands and thousands of people around Newcastle in response to the recent cases without picking up unsuspected community cases. Superb response, and the same's been happening across Sydney. So I can't tell you what the ratio is. There will be additional community-based cases. Clearly there were in New Zealand, where there were no cases for a little while, and then it's popped up. So we know COVID can do that and can lay low. But we can be reassured by the really high levels of testing we have. And I mentioned the sewage surveillance. I mean, that will play into part of this reassurance in time. We get back to that situation where we have no community unexplained cases popping up and no detects in widespread sewage sampling. That'll add to our level of confidence that we're not missing substantial numbers of people in the community. Thanks, Catherine.
Thanks, Tony. There's a couple of questions here about what's happening in Victoria, which, look, I know we're all watching with, I can't even find the right words, around that. So there are some questions here about, the situation that's going on there. What are we learning from there? And Katie, I know you had some comments in your slides about that. I wonder, are we in a place yet where we can say, what would be, I'll ask the panel, what would be one thing that you would advise that might prevent us being in a similar situation in a few weeks' time?
Yeah, so the importance of wearing the appropriate PPE at the appropriate times. So the importance of PPE, so if you're faced like in the clinical setting, if you're to look after probable suspected cases, then you really have to be mindful about how to use PPE well. So including the donning and the doffing of the PPE. So education about how to do that, and also because of the rapidly changing advices, so to have the healthcare workers updated with the PPE suggestions and advices. Because what we saw in Victoria, so they didn't have the general population wearing the mask until a little bit later on. So but it escalated very quickly. So and also healthcare workers, so to activate the use of mask wearing amongst healthcare workers, at the time of these outbreaks. So we just have to be mindful about what advices. So based on what the government is telling us. So and that comes down to the level of transmission in the community. So in public health units, we are given the very useful information in terms of what level of transmission there is. So Tony will be able to tell us whether whether our community, our area has low level transmission or high level transmission, or we're escalating accordingly. So in Victoria, similarly, so they had escalation quite rapidly. So we just have to be still alert meantime. So it's still winter. So we have had cases in the community. So we have to be mindful about what changes there are in the coming future. So, and then, so listen carefully. Yeah.
Thank you. Mel, have you anything in terms of residential aged care? I know that's where a lot of your work's been, that you think is good advice for people?
I guess from my perspective, I just wanted to take an opportunity, if I could, also to promote some of the work that we're doing. And one of the things key to that, Catherine, is some of the tabletop exercises that we've just started, which you mentioned at the very beginning. So Central Coast Local Health District have started only this week, but we will be continuing over the next coming weeks, engaging with the residential aged care facilities on the Central Coast and inviting them to participate in some tabletop exercises together with our pandemic lead and her team, as well as the Public Health Unit, Infection Prevention and Control, PHN, and we have also been able to engage a GP with our session this week, which has been fantastic. So that's a great opportunity for us really to go through a couple of scenarios. One is, I guess, the scenario where staff members become unwell, and then returned a positive case. The other is then when some residents have also returned some positive cases, and we just talk through what are some of the aspects that need to be considered and making sure that we really have a strong plan in place so that we are prepared. And through that process, we're able to identify with the facilities any gaps that there may be and help to try and work through some of those gaps to make sure that we definitely are prepared and planned as much as we can. If I can just add a little bit on top of that, Catherine, just in regards to our aged care response team on the Central Coast, it's really just to remind those residential aged care facilities that are online that we have our aged care response team on the Central Coast that are able to provide some support at the facilities through either education and training or also just through clinical reviews and comprehensive assessments of residents within your facilities. We have been able to streamline access to that team by going through our Community Health Access and Intake Service, which is our 1300 725 565 number. So please do, if you do have any residents that you may be concerned of, or you would like to have a conversation around any education needs that you have, please make a call through to our intake line and we can try and see how we might be able to support your facility with that.
Thanks, Mel. Tony, I'm going to put you on 1 minute responses here. When should we retest patients who have ongoing symptoms and previous negative COVID tests? And
important question, and look, not a black and white answer, of course, because it depends on your level of suspicion. There have been times when we were really suspicious, given the epi, and waited 2 days and tested again. And but I guess it will often be somewhere between 2 days and a week, depending on what people are doing clinically and what the context is. Yep. So no magic number there. Be guided by your level of suspicion.
Thank you. Katie, this is a very quick one. Is a face shield as effective as goggles for eye protection?
Yeah, that's a good question. So it is an effective eye protection for face shield. So, so just a point, face shield should not replace face masks. So in regards to droplet precautions, so face shield is effective eye protection only. Okay, yeah. So now, so we see people with face shield as well as face masks. Okay, yeah. So but that's for the healthcare setting. So but in the community setting, so you can where there's less concern about like community spread, or where it's not when you're using the face shield not for clinical purposes, then you may consider just wearing a face mask for these non-clinical reasons. So, but face shield is an effective eye protection in the healthcare setting only.
Thanks, Katie. And we have some quite groovy ones that have been donated by one of the motor racing teams if people need some from the PHN. Last question, and this is probably not a short answer, Tony, but one for us to take to another day. What would happen if we had a case, so I guess somebody who was sitting in a GP waiting room who later was identified as a positive case?
Yeah, the principle is simple, but obviously application can be tricky at times, and our role is to identify the close contacts, so people within 1.5 meters for more than 15 minutes, cumulative over the week, or in the same airspace for 2 hours, and those with the inadequate kind of personal protective equipment. So any people who trigger that close contact definition, we'd be putting those people into quarantine for 14 days and keeping a close eye on them. And clearly that drives a lot of the sensible precautions that you've taken in terms of not having people building up in numbers in waiting rooms, anyone with symptoms wearing a mask, which mitigates the risk for others, and obviously keeping people out of practices and practicing telehealth. Yeah.
Thank you. And obviously the public health unit would be very much involved in assisting the practice in what to do next, so we can reassure people that that advice would be forthcoming.
Yeah, absolutely.
Okay, well, it's 7:31. We've had a few technical problems tonight, so thanks for sticking with us through this. As always, I've learned lots. Hopefully you have too. So I'll thank each of our panel. I'll thank all of you for the questions. I acknowledge we didn't get to all of them. Some of them are really challenging, and we will continue to try and address these in forthcoming events, except for the one about closing the Hawkesbury River Bridge, because there's still the train line and boats and all sorts of things. So we'll remind people to please go onto Slido, pop some evaluation points in there to help us improve these sessions. There will be another one. I don't have a date, but we're planning sometime in the next few weeks, couple of weeks at the latest, really very much focused on residential aged care outbreaks, what happens, who's involved, and really, as Mel described, we're going through this in a much more detailed process at the moment so that we can really be clear with each other as a coordinated team on who's doing what and how we're going to best support the people who are living in those facilities and the people who are looking after them. So again, thanks everyone for the huge amount of work everyone's been doing. It doesn't even seem like enough words. It's a really frightening situation, and watching what's happening just so close to us in Victoria, we're learning so much from them, and I'm sure many of us are having conversations with them, which is bringing that intel back to here and just trying to make sure that we stay one step ahead of this awful, awful virus. So thanks everyone, and with that I'll ask the panel to wait for a minute, but Jenny, I'll ask you to say good night. Thank you.
Good night, and thank you, everyone.
Thanks, everyone.
Thank you.
Is that a wrap? Is that a wrap, Jenny?